Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. I'm Kurt Barwis, your host. Today, and it's kind of an unbelievable thing we're going to talk about, but we're going to talk about how to avoid hip surgery. We're going to talk about the things you can do to potentially never have to have that hip surgery. And with me today to talk about this is Dr. Lebaschi. Welcome again to this show.
Thank you so much.
It's great to have you.
Thank you, Mr. Barber. Thank you very much for this opportunity. As you said, hip replacement, the final treatment for a bad hip, is very common these days. A lot of advancement to make the results and outcome way better than what it was before. Implant design, technique, patient selection, rehab, using robot and navigation, all these have made this surgery phenomenal.
Yeah.
However, if you go and ask single individual patients, they have gone through a long journey, suffering, pain, dysfunction, discomfort, missing activities they wanted to do, missing activities they enjoyed doing before they came to the point that hip replacement was the right procedure for them. Despite all those advances, there are people, smart people, who are looking at what has gone wrong for these patients that led them to state that the hip joint is burned out and nothing else can be done. Nothing works other than a replacement. And there have been remarkable advances in understanding of what problems these patients could have had before the hip reached to an end-stage position.
So you're saying is there's this newly developed kind of playbook that if you follow it and you do certain things, you can potentially avoid the pathway.
Well, that's definitely one category of this playbook. Certain things that you can do, but there are a large number of patients who are born with problems or acquire problems based on their activities or their genetics or the environment that puts them at risk of getting a hip replacement. And it's a musculoskeletal problem, but it's not going to harm to consider other diseases as analogies, like colon cancer, like lung cancer. People do certain things or are born with certain things that make them more prone to developing those bad conditions, requiring extensive surgeries or long recovery and potentially a fatal outcome. For hip, the same thing also holds true. What I want to talk about today is to see if we can catch patients with those conditions earlier, and with lifestyle modification, with, well, I want to say medication, but non-operative management strategies or potential surgeries, we can correct that underlying problem and prevent the hip from going bad. Another analogy would be a car that has malaligned tire.
Yeah.
A car
It's
doesn't balance.
expensive. You got to replace those
Exactly,
tires,
exactly.
right?
You can check your car and see if there are signs that this tire is getting worn on certain spots that would eventually lead to loss of all the treads.
Yeah.
And at that time, unfortunately, if you go back and correct the malalignment, it's too late. The tire is not going to function. This last analogy, I think, is what makes a lot of sense for most of the joint problems, specifically hip. I actually have a model here that can help understand what you're talking about. And this is the pelvis bone, and this is the socket for the hip joint. And this is the thigh bone and the ball part of the hip joint. And this articulation becomes the hip joint. It's a very complex, deep structure, lots of muscles, ligaments, tendons around it. And the inside of the joint is covered by cartilage, head of the thigh bone and the inside of the socket. All we're talking about is to preserve this cartilage from being worn. The same thing as treads of a tire. One thing that people might think is that arthritis is not something that goes into the joint, but something that actually leaves the joint. And that's the cartilage. Cartilage is a highly specialized tissue with very limited or non-existent capability to heal. Once cartilage is gone, it's gone. It doesn't come back. Active research is underway to figure out if there is a way that we can restore the cartilage, but success so far is limited at best. So what we need to do is to preserve this cartilage from being lost and the joint deteriorating, becoming a painful, stiff, dysfunctional structure. Looking at patients who ended up with having severe arthritis of the hip joint, there are a couple of categories that could be recognized. And these are the things that we can intervene. One is that the hip joint is made too shallow. This is called hip dysplasia. It's a very common condition, more common in female. There are geographical variations. You don't see them in some parts of the world, and you see them a lot in others. In this condition, the socket is not deep enough. It's dysplastic, means that it was formed bad, not deep enough. That would lead to under coverage of the head of the thigh bone, and instead of the thigh bone being covered by the joint, so that through the range of motion when we sit, this is a simulation of how we sit. This is the simulation of how we walk. So the coverage of the femoral thigh bone head is inadequate, and this leads to loading of the head of the femur at the edge. Instead of loading the entire surface of the sphere, the edge is being loaded. It just like a malaligned tire, or someone walks on the side of the shoe. So
somebody that has that, you can see that when they walk?
Most of these are identified through extensive programs at early childhood or shortly after birth. So many of them can be identified with exam or x-ray or ultrasound. We have a protocol for that. A vast majority of these patients are caught when they are younger, and we have strategies to treat them so that by the time the kid grows, we have more coverage of the head of the thigh bone. Unfortunately, a portion of the patients go unnoticed, and they take this malformation, shallow acetabulum or shallow socket, to their adulthood. We call it residual dysplasia. For some reason, they went unnoticed. They didn't have.
So for parents, because obviously this is your whole life, right? I mean,
exactly.
It's going to deteriorate. What can they do? Should they, I know sometimes sports physicals, for high school, but they're already in high school now. They may have a full exam that could potentially catch this, or should they do them earlier for their kids?
The main strategy or main weapon against this problem to be carried over to later years of life is to detection of this problem early, at early childhood, within the first year of life. Most of the time, our pediatric colleagues, orthopedic surgeons who are active in pediatric age group can do that, can identify it. But for some reason, like any other condition, this can skip notice and be carried over. The presentation of this problem could be a limp, could be leg length discrepancy, because when the socket is shallower, the thigh bone rests a little bit higher up, so that leads to shortening of the entire leg. There could be weakness of the hip, and could be subtle symptoms. I feel like feeling of instability, as if the hip is coming off, and something is not right, or ultimately pain. All of these can happen. Usually these present in early decades of life. This usually presents within the second or third decades of life, and patients come to us and we figure it out. Oh, there is a dysplastic hip.
So can a pediatrician, so baby's born, they come up, you're going back for your follow-up with your pediatrician. Do the pediatricians know to look for this?
Yes, they're all trained. And they do a great job in finding and doing screening tests and referring them to orthopedic surgeons. There is a national guideline based on some risk factors. Like we have specific ones like family history, firstborn, those were born breech, means that the baby was upside down. Because when the baby is upside down, the hip position inside the uterus is tighter and might lead to subluxation or moving of the head of the thigh bone out of the socket, and that would lead to inadequate development of the socket. So these are all the things. I don't have a good number, but the vast majority, I would say, more than 90% of these are caught with our modern approach of detecting this devastating problem. But if it's carried over to later in life, then you have a setup for arthritis. What can be done if we detect this earlier, before the arthritis sets in? It's a very interesting surgery, and that's we make series of cuts around the socket and free up the socket and realign the socket and move it in a way that the part of the thigh bone that is not covered is now covered. It's a procedure that a great surgeon in Switzerland devised, Professor Ganz, and from there most people have followed his guideline. It's a phenomenal procedure. It's not an easy thing to do, but that's the gold standard of figuring out and of controlling the and correcting the shallow socket. We cannot make it deeper, but we can reposition it so most of the coverage is restored.
So basically, you preserve the cartilage. You don't touch the cartilage that's inside the socket.
Exactly. If you let
you move the socket, and so you would want to do that because all those years of problems and pain, which ultimately lead up to potentially a bigger surgery. So the idea of doing the surgery early and doing that just kind of either eliminates or reduces all these other problems you're going to have.
Exactly.
That's incredible.
That's incredible. Exactly. This procedure is meant for the time when the patient is skeletally mature. If we catch it earlier, we still have other less extensive ways, because the bone is still pliable, the bone is still growing, the growth plates are still open, so we can do other less extensive procedures. But once the growth plates are closed and the bone is skeletally mature, which usually happens in girls at the age of 14 and in boys at the age of 16, then we have to cut the bone and realign it. This procedure is now the gold standard for treating high level of dysplasia or shallow acetabulum or socket, and is very successful and has been shown to push back the need for hip replacement down the road. And if they need hip replacement down the road, it doesn't prevent us from doing that. That's another thing. So this is one great example of underlying problems with the hip that requires hip replacement. Another category of the problem that could be identified in patients who ended up needing a hip replacement is what we call it femoroacetabular impingement. Femoroacetabular impingement. What is that? This socket and this joint is very congruent. However, it still allows us to have good range of motion. It's not like shoulder. We don't have the range of motion of the hip that we have in shoulder, but it's still pretty good range in all directions. However, as you can see by design, the edge of the socket and the shape of the thigh bone is in a way that would allow us to bend our hips without impinging and without hitting this part of the bone, which is the neck, to the edge of the socket.
Yeah.
For some reason, in patients, this nice transition or this spherical configuration of the head and this nice divot that you see here is not there. The head is not spherical, or there is a bump here. That bump, we call it a cam lesion. When the patient affected by this type of problem, instead of having an impingement-free range of motion, hits that bump against the edge of the socket. There are soft tissues around the socket that are in continuity with the cartilage inside. So each time this happens,
you're taking a little bit off.
Exactly. And then it's just a matter of wear and tear, accelerated wear and tear. It's just like having a piece of rock trapped in the treads of the tire, and over time it leads to deterioration. Another example is that some people are born with much deeper socket, and their coverage of the thigh bone is more than it should be. These conditions represent another type of impingement, that the divot here and the sphericity of the femoral head is adequate, but there is just too much overhang of the socket. But the same thing happens. And sometimes people are born with a combination of these two. They have features of both. All these are precursors of damage to the cartilage, irreversible damage to the cartilage, and onset of arthritis. I just saw a patient this morning that was complaining of severe hip pain, gentleman in his 40s. He couldn't take it anymore, and I saw the X-ray this morning, and I saw that he had underlying cam lesion, femoroacetabular impingement, that I'm confident happened many years ago, but it was now too late to do anything. What can we do about this? We can go in and shave off this bump, or shave off the edge of the socket and repair the soft tissue tear that is in continuity with the cartilage, and save this joint from going down.
That makes so much sense. I mean, it reminds me of carpentry, to be honest
Exactly.
with you. But it just makes so much sense. And what I'm hearing you say is, when you go in to do a hip replacement surgery, you're seeing these things that have been left, not identified, not treated, and now here we are, and now we've got to do the hip replacement.
Unfortunately, when the time is right for hip replacement, horse is out of the barn.
Yeah.
Correcting the underlying problem is not going to restore the lost cartilage, and that's the sad part. And then we have to replace the hip. There are other conditions that would lead to hip replacement. As you can see, the head of the thigh bone is very much like an ice cream on a cone.
Yeah.
When humans are in growing phase, they have growth plates. They're like a carpet that is made on one end, and the carpet becomes longer. The bones work the same way. There is a growth plate here at the end of the thigh bone, and there is one growth plate here that leads to lengthening of the bone. This growth plate represents a weak spot because it's not fully ossified, or it's not made of bone yet. For some reason, in certain kids, the head of the thigh bone becomes detached from the rest of the bone at the growth plate. Usually it moves back, just like an ice cream falling off the cone. This leads to severe malalignment and malfunctioning of the hip joint. A very This is called SCFE, or slipped capital femoral epiphysis. It's a common condition in kids around the age of 10 or a little bit younger. If this goes unnoticed, then it's a recipe for arthritis down the road. Not just that, the deformity that persists makes the surgery harder as well. These patients usually present with pain and limp. We usually catch them, and we can fix this problem by keeping the head of the thigh bone in place, or just going in and putting it entirely back. Another condition for...
Hey, could you clarify? So arthritis. So as the cartilage wears out, then that's where you end up with arthritis, or is it a completely separate condition?
No, that's the definition of the arthritis. Irreversible, extensive loss of cartilage.
Wow.
And
okay,
everything
thank you
else,
for that.
yeah,
I didn't
and
realize
everything else are consequences of this loss of cartilage. The cartilage is there to cushion, to lubricate and absorb the shock. Once this function is lost, the bones see more pressure.
Yeah.
And as a measure to adapt to this increased pressure, they undergo some changes. But unfortunately, all those changes are maladaptive. They cannot restore the function. They form bone spurs. The purpose of the bone spur is to increase the area and decrease per unit area pressure. But those bone spurs cause more problem. The bone becomes stiffer and harder. We call it sclerosis. As we get an x-ray, we see that bone is wider. It means that this bone is seeing more pressure. A wider bone is more brittle and is more painful. And sometimes cysts form. So all these changes are secondary to loss of the cartilage and absence of cushioning effect of the cartilage.
Yeah.
Just to conclude, this is a very extensive topic. There is another condition that can happen in kids, and that's called Perthes disease. 3 orthopedic surgeons actually describe this procedure, this disease, but it's mainly known as Perthes disease. And that's the condition where a part of the thigh bone just dies, loses its blood supply, and that part collapses and becomes flat. The sphericity of the thigh bone head is lost, and it's as if you're replacing a round tire with a square or oval one. And that leads to arthritis of the hip joint very quickly, very, very quickly.
So again, loss of the cartilage, which causes all these other problems.
Exactly. This joint and most of the joints are designed to have smooth surfaces, correct distribution of forces, and free range of motion. Unfortunately, it has very low tolerance for deviation from any of these optimal scenarios, and that leads to... So these are the main things that we can catch and correct before the hip joint is actually lost or burned out. Many of these conditions are not asymptomatic. They are painful, they are uncomfortable, and clues the patients in that something is wrong.
And a lot of people kind of live with that often, and they accept it. And,
unfortunately, that's what puts the last nail to the coffin. Just ignore it.
Yeah.
That's what leads them towards the end stage of the cartilage.
Which gets you to the bonus round, which is the surgery, which nobody should, if we can avoid that. Dr. Lebaschi, thank you.
Of course.
Thank you very much. Unfortunately, we're almost out of time here, I think, today. And it just went really fast because just listening to you talk about it and putting it in a way that, the average person can understand is really, I think, important. Because if more people can catch it earlier, they're going to have a better life, better outcome, and be a lot more functional, be able to do things better. So I think this is really exciting and really important for people to hear. So this is Bristol Health Cares, and very exciting episode. And I want to thank Nutmeg TV for really being a great supporter of this program and a great supporter of the community. And so please, it's a nonprofit organization. If you have the wherewithal and the ability, please donate to Nutmeg TV. And until the next episode, again, you can write us at cares@bristolhospital.org. It's cares@bristolhospital.org. If you'd like to hear about something and I can bring it onto the show and help you get more information, that's what we're here for. We're here to really help you connect with better health and a better life. So stay tuned till the next time. Have a wonderful day.